Welcome and greetings from New York. Warm welcome in what here proves to be a rainy and snowy day. I want to thank you very much to a shout out to the people at CyberSight, especially Andy Chen, who's guided me through the logistics of this process. Today we're going to cover anterior segment challenges. My name is Professor Mitchell Dool. I'm in the Department of Biological and Vision Science at the State University of New York, College of Optometry. This course, the behavioral objectives for today in the description, this will explore the diagnostic challenges involving anterior segment disease and adnexa. And I'll reinforce the principles of differential diagnosis and Bayesian logic and predictive values of the assessments. So the first case, for instance, we'll break down, I'll give you a case example, and then we'll go over Bayesian principles and how we might best apply those. It's not complicated at all. In fact, it's something that you do every day. You may just never have assigned a name to it. But we're clinicians and we think in a logical way, and that has served us well. There are, however, times where we believe that we're on the right path, and we need to deviate from that when a new finding occurs, or when there is an addition into the history, where things just don't look as we expect them to look. But as clinicians, our education is steeped in science, so we will approach this as a scientist, and when we see a clinical case, we develop a null hypothesis based on entry history and entry tests. And then it's our job to either support or refute that hypothesis. And as I say, it's something to do on a regular basis, but may not think about it in those terms. So one of the points here is to help us to understand what a next step would be when we're going down what seems like a logical path and our null hypothesis proves to be wrong. We'll start with a case of a 72-year-old female. She had a sudden loss of vision in the right eye following a traumatic head injury. This patient fell backwards on an icy surface and struck her head. She experienced loss of consciousness and a concussion, and she reported to the emergency room by ambulance. Her medical history now is significant for a moderate traumatic brain injury for the past 4 weeks, and she's under the care of a neurologist. The neurologist sought an eye consult to work up the patient's complaint of a loss in visual acuity. She has a known history of hypertension and prediabetes. She's also been a glaucoma suspect. She has pseudoexfoliative glaucoma. She has pseudoexfoliation in each eye, but no manifestation of clinical glaucoma. She's also a high myope in each eye and status post extracapsular cataract extraction in the left eye. And she was scheduled for the procedure in the right eye 2 weeks before the injury. The visual acuity with her habitual spectacle RX in the right eye, the spectacle RX corresponds to her myopia is minus 950, minus 150 at 23, and her acuity is count fingers at 2 feet. Her BVA in the eye that had the ECCE is 20/25 uncorrected. Now, I can tell you this was an established patient of mine prior to the trauma, and the neurologist sent her back to me for this workup. I can tell you that her acuity had been prior to cataract was 20/25 also. So over the course of time, she developed cataracts and sought the counsel. I sent her to cataract consultation, and when I was done, they were getting ready to do the other eye. So to summarize this briefly, we have a decrease in visual acuity, and in this case, in one eye. One moment. Oh, I have many computers in front of me, so I'm mousing on one and nothing's happening because I have too many mouses. So this is a Bayesian sort of setup. What we do is look for common things first because they happen commonly. We reserve hunting or exploring uncommon things because they happen less commonly. And I know that sounds almost too basic for a lecture to such a distinguished audience, but even seasoned clinicians lose sight of this on occasion, and we end up getting what this ends up uh, uh, promoting is the use of tests that each time you do an exam, a particular assessment tool, you run the risk of having a false positive. And the more uncommon something gets, the greater the risk of false positives, because tests' sensitivity and specificity decrease as the prevalence of these conditions or the predictive value of those tests decreases as prevalence decreases. So we start simple, and we do this very quickly. It's not as if we're really wasting time, and it's not a coincidence that our clinical examination is organized this way. So for instance, decreased visual acuity most commonly is a consequence of refractive error. And we address that early on in an exam, also by history, by the way. Even a good history will sort this out. But we do visual acuities. We do a pinhole, and we'll do a refraction to rule this portion out. Our next most common thing is media opacity. And of course, the most common there is cataract, but the anterior segment, the aqueous, is media. The cornea is media. And frankly, to be fair, your spectacles or contact lenses are media as well. And, I wish I had $1 for every single time I solved the patient's decreased acuity by cleaning their glasses. So media is the next most likely cause of decreased visual acuity. And our assessment tool with the highest predictive value here is the slit lamp. So we're targeting conditions with examination or assessment tools that have the highest predictive value for that category. The next is retina, and specifically the macula, and a dilated fundus examination or an OCT, for instance, would be highly specific for that and have high predictive value. Optic nerve assessment, pupils, which is we do very early on in the external examination, can be really telling and very, very important to guide you in your subsequent analysis. Stereo dilation, so stereo assessment of the optic nerve through a dilated pupil. Visual fields will also help with the optic nerve. They'll also help with the next tier, which is the visual pathway. Visual fields can help determine where along the visual pathway a defect may be. Also neuroimaging, so fields would be the structural side, the functional side, neuroimaging would be the structural side. And then miscellaneous. Miscellaneous can be things like malingerer. Miscellaneous can be more obscure cases that still need attention, but we shouldn't lead with that and say get a full body MRI and the chance of having a false positive is so high. We end up basically with assessment tools chasing our tail. So we start with the common and hone down and consider the uncommon when it's time to consider the uncommon. And an example of an assessment tool for someone with malingering would be a tangent screen, for instance, or electrodiagnostics. So back to our case. The externals on this patient were unremarkable. Her pupils were normal. They were equal, round, respond to light, and there was no evidence of an afferent pupillary defect. The refraction was plus 350, minus 150 at 25, and her acuity in this case was 20/25 in the right eye and 20/20 in the left eye. The slit lamp showed apparent aphakia in the right eye and an extracapsular cataract extraction with an IOL well-centered and placed in the left eye. So, throwing it to the group. Based upon the available evidence and clinical information, what is your provisional diagnosis for this case? So we have a really mixed bag here. The macular edema with a corresponding hyperopic shift is possible. She is a pre-diabetic. It's also possible that macular edema could occur in the setting of blunt trauma in the form of what has been called Berlin's edema. It's like commotio retinae, for instance, but it's specific to the macula. We would have seen that, I believe, in the fundus image, although early on, it's conceivable that we might not. Hey, Andy, if you wouldn't mind, you pop up those answers again. I'd appreciate it because I can go through each one of them. Thank you. Um, so it is possible. Berlin's edema is something that takes a while to clinically manifest, and the patient sees nothing out of that eye, and you see nothing. However, this patient was correctable to 2025. Uh, Retrobulbar optic neuritis is another possibility. The optic nerve, as you know, is tethered to the apex of the orbit, and so head trauma with concussion, with the movement of the brain, can pull on that area of the optic nerve where it's tethered intracranially and cause swelling of the nerve at that point. And in that instance, the patient will see very little, and you'll see very little because you don't see the Wallerian degeneration or anterograde degeneration that will occur subsequently. However, we would expect a pupil to be dysfunctional in that eye, and the pupils here were within normal limits. Malingering is within the realm of possibility, although we did correct her to 2025 with a hyperopic correction and someone who was previously a -9. So that plus lens, if she was malingering, would make her see even worse. Traumatic subluxation and dislocation. This is just a matter of semantics. The question is, where is the lens? And at the slit lamp, prior to dilation, there appeared to be no lens at all, which would suggest that it was dislocated, not subluxed. Every case of subluxation that I've seen some portion of the lens in the slit lamp. So thank you, Andy, for that. You can close that. So traumatic dislocation of the lens is a null hypothesis here, even though, going back to this briefly, I think for many of us, that would have been low on our list because, refractive error as a sudden, responsible for sudden loss of acuity is quite uncommon. And retina and optic nerve would be more common. So I understand the logic of the other choices. But when I did a peripheral fundus examination on this patient, lo and behold, there's her crystalline lens sitting in her vitreous cavity. That patient was then, you have to forgive me here. I downloaded a different copy on this. This is just notes to myself, but I did send this patient for vitreoretinal consultation, and the surgeon has elected to leave it there. They referred the patient back to me, and I've subsequently fit the patient with a contact lens. She's very happy with that. She doesn't need the ECCE at this point, and this patient's just routinely monitored by myself and the retina person. Here's an example of a sublux lens with a UBM and a sublux lens on MRI. Of course, lenses can be subluxed anteriorly as well. This is a medical emergency, as you might imagine. This is an eye where the anterior chamber has a crystalline lens. The trabecular meshwork is compromised in the region of touch. Synechial closure is likely to occur. Here's this a similar eye in an anterior segment OCT. You can see how this eye has subluxed anteriorly. You have the risk of significant endothelial damage as a consequence of this touch. And just a reminder, this patient essentially had a cataract procedure that was done a long time ago. This was sometimes referred to as couching. A piece of bamboo or other sharp instrument was placed through the cornea, and the nuclear sclerotic lens, which was dense, would be pushed through the posterior capsule and into the vitreous cavity. It was the primary form of cataract surgery until the 1700s. As you might imagine, it had a poor success rate. You had prolapse of vitreous into the anterior chamber, potential for retinal detachment as this vascular fibrotic scar could occur around this and pull the retina off. Okay, our next case. A 42-year-old male. His chief complaint is pain on eye movement in the left eye during a deduction for the past 3 weeks. By the way, I saw this case just 3 weeks ago. Steadily increasing in intensity over the past several days. Medical history is unremarkable. There's no history of recurrent or current upper respiratory infection or sinusitis, no redness or swelling of the eyes or adjacent structure. His eyes look quiet. His acuity is 20/40 in the right eye, but that's long-standing anisometropic amblyopia. His left eye is 20/20. Externals show no evidence of proptosis. His extraocular muscle movement is smooth and full, but during testing of the extraocular muscles, he reports eye pain when he looks to the right. His pupils are normal. The slit lamp is unremarkable. So I asked the patient to sit back and just, tell me, point to the source of pain. And he touches the center of his right upper lid, which he reports is painful. Left upper lid, that's on me. So he points to his left upper lid. Based on this question and clinical diagnosis, clinical presentation, what is your provisional diagnosis based on your clinical experience of pain associated with the upper lid and or with eye movement? But under these circumstances, what are your rule outs? I mean, this guy's age, multiple sclerosis was honestly, that was high on my list as well. In fact, I think I let that bias me so much that I skipped over some very common things that happen commonly. And yeah, that was where I was heading. The pupils here were normal. So that suggests that decreases my probability of MS. Of course, I'm going to continue to do an examination. I'll show you what the findings were. Orbital rim fracture. He had no history of blunt trauma, but I did palpate orbital rims, and the pain just wasn't there. External hordeolum. I think we would have seen the external hordeolum at slit lamp, or even on externals. Internal hordeolum. That's where I was headed. Pain on palpation, the patient touches it and goes, ow. Even though it's associated with eye movements, that's a very, very, very common sign for a common condition. So I think we had to pay attention to that particular differential diagnosis. And sebaceous gland carcinoma, he's very young for that. He has no history of radiation therapy, low on my list, but these are all things that are worthy of consideration. Okay, thank you, Andy. So given the constellation of signs and findings, my differential at that point, my null hypothesis was internal hordeolum. But it got interesting because this is where my Bayesian logic sent me one direction and then there was a change. His IOPs were 12 millimeters of mercury in each eye. Gonio was open to 360 degrees on the outside chance that he, might have chronic angle closure or intermittent angle closure. But after I did gonioscopy, the patient sits back and smiles at me and he starts looking left and right and he goes, this pain is gone. So now that's an unexpected, very unexpected finding for an internal hordeolum. A topical anesthetic should not make it go away. So I finally get around to palpating his lid, which I should have done a long time ago, and there's no palpable mass there whatsoever. So throwing it to the group, based on this change of events, what procedure would you do that would have the highest predictive value? The group, the most common answer was lid aversion. And yeah, it's something I should have done during my slit lamp examination. I was literally right there, but I was just so concerned about other things that I let it slip. So lid biopsy, if I were to expect a sebaceous gland carcinoma, would be indicated. Culture and sensitivity, I would if the eye wasn't white and quiet, but it was a very quiet eye. My biography couldn't hurt. Excision and curettage, that's if I had the internal hordeolum, but I wasn't convinced. I needed to avert his lid to see if that was the case. So I did. And this is what I saw. He had these very large concretions, and he had them in both eyes, but they were much worse and had actually come through the palpebral conjunctival epithelium. And what I believe was happening, the sensation wasn't the lid itself, but it was his cornea as his limbus scraped across and his superior cornea scraped across these because they looked like little barbs. So topical anesthetic, I gave him both eyes so I can control eye blinking. I averted his lid. I soaked a cotton tip swab with the same proparacaine and just held it here for a while to just increase the anesthesia in this area, and took a 20 gauge needle. Some people use, larger needles. I have 20 gauge readily available, and just scraped these off, flipped his lid back, broad spectrum topical antibiotic. I gave him an ointment for the contact time to take at night. And he works in my lab, so I could see him on a regular basis, but he was happy for the rest of the day, and he's had no reoccurrence for now. And at least we got to the bottom of it. But this was an internal hordeolum until proven otherwise, and we proved otherwise. Our next case, a 68-year-old female. She complains of redness in the right eye upon awakening in the morning. This is her quote: "My eye was red when I looked in the mirror this morning. Quote, it looks as if it is bleeding." Her medical history is unremarkable. She has no history of recurrent sinusitis or any other inflammation around the sinuses or eyes. No trauma. She's had no Valsalva maneuver, no heavy lifting, no straining. I think you know where I'm going with that. These are the types of questions you'd ask in this scenario. No history of anticoagulant medication use. She's 20/20 in each eye. Remember, I'm on the phone, right? She comes in, so I'm expecting to see something. I'm curious to see what it is you would expect to see based on this limited clinical information on the telephone. What's your provisional diagnosis? The big winner here is subconjunctival hemorrhage. That's exactly where I was going with this. Viral conjunctivitis, no antecedent upper respiratory infection, the eyes were white and quiet. Hyphema, we have to put it there because it's also, it's blood that's passing through a blood vessel, and you've got a handful of spaces that we could be in, and subconjunctival space is one, and clearly anterior segment's another. The anterior chamber. A penetrating injury to the sclera, she would have reported that. The eye would have been red. And she's not a contact lens wearer, so we wouldn't expect overwear. So yes, my provisional diagnosis, based on common things happen commonly, would be a subconjunctival hemorrhage. This is how she presented. Now, I mentioned her visual acuities were 20/20. She has an apparent hyphema here. Her pupils are normal. Slit lamp confirms the presence of hyphema because I saw the hyphema on externals. I also noticed that she had an ECCE in each eye. She's status post cataract surgery. Her IOP is 9 and 11. Now, I'm not going to send this to the group, but what's unusual about this appearance, we expect to see hyphema settling like a high water mark across here, and that's not what we see. And the only times I've ever seen these, and I used to work in a hospital where I saw trauma very commonly, were people who were found in a horizontal position from trauma, and who were picked up off the street, usually by police officers, sent to the hospital. ER doc saw the blood, I would get called in, but these patients were in a horizontal position, so that would account for that. So this position and the fact that it hasn't leveled off is unusual. It's also dark, so it's just kind of odd that it's that dark because she just noticed it, but that suggests that it's been there for a while. So again, this is what we expect to see. This is what we're seeing here. So hyphema like this, when she just woke up, tells me that this occurred while she was sleeping. And so we need to explore that further. Now, we have a lot of tools for looking at hyphema. There are a lot of clinical appearances associated with it. Sometimes you have a diffuse hyphema early on, which then it gets more dense. It obscures the view of the posterior pole. That's your optic nerve. This is anterior segment OCT, where we can see through the blood to a point. And it's just a nice augmentation of the image of this, and it's just a nice assessment tool to have. Now that we're in the domain of hyphema and not subconjunctival hemorrhage, we have to look, well, let's look at how this happens most commonly. And we know that either planned or unplanned trauma is by far the most common etiology. But the patient reports no trauma, at least no unplanned trauma. But there is such thing as planned trauma, and that's the surgical intervention. So we had to do a deeper dive into that because that's the only trauma she sustained. She doesn't have rubeosis of the iris, that was obvious. And then everything else in this category are very uncommon things that can be ruled out very easily by history and clinical observation. So the slit lamp did confirm the presence of hyphema, but she did have ECCE-OU. So on further inspection with both gonioscopy, but actually more visibly with the anterior segment OCT, it was pretty clear that she had a flap of trabecular meshwork. It was 360 degrees. This patient had a glaucoma procedure, a MIGS procedure at the same time. And that became more obvious from her history because prior to the glaucoma surgery and cataract surgery, she had a known history of open angle glaucoma. And she said that after the ECCE, which was just 3 weeks ago, they DC'd the glaucoma medications. So that suggested to me that she had glaucoma. She didn't have it after the procedure. And yes, you expect a 1.4 millimeter drop from just the cataract surgery alone, but there must have been a secondary procedure, and that was confirmed on anterior segment OCT. So when I finally did track down her surgical notes, she in fact did have a gonioscopy-assisted transluminal trabeculectomy. This is running often suture material through Schlemm's canal and then pulling it through to then expose the trabecular meshwork and allow aqueous humor to filter through the eye directly into Schlemm's canal. This is here more for completeness. This is a more traditional way of managing traumatic hyphema. These are notes to you if you'd like to refer back to them. I think the caveat here, the most important is we typically avoid miotics. I know there are people who build a case for that, but they're pro-inflammatory. They increase vascular permeability. And then if I need to do a DFE later, if the patient has a complaint, I need to counteract that. So I typically avoid those. Prostaglandins, also, they're good for IOP, but they're also pro-inflammatory. I'll try all of these other combinations first. And then criteria for surgical aspiration, more often than not, hyphema is managed non-surgically. But there are, red light scenarios or push button thresholds that if they're crossed, the patient should be offered surgical management, which is aspiration and washout of the blood in the anterior chamber. Special shout out to patients who might have sickle cell because you need to be more aggressive. Our particular patient put a Fox shield on her during the night. We can talk afterwards about why it is this happens after goniotomy. The fact that her IOP was so low to start is a hint. And as to why it was when she was laying down, just quickly, you now have a significant imbalance between the venous pressure and episcleral venous pressure and her IOP, and blood then just retroflows through most likely the vein of Asher and through Schlemm's canal right into the anterior chamber. Next case. This was a favorite of mine because I got to know this patient well. He was referred by a neurologist in my area for an eye consult. The patient's chief complaint was intermittent pain on the left side of their head for the past 2 weeks, accompanied by kaleidoscopic halos around lights and headache during these episodes. The neurologist asked me to rule out ocular migraine. The past medical history was that the patient had presented to their primary care provider at the onset of this unilateral pain and was treated with acyclovir on the assumption that this person had incipient zoster, which actually never occurred, but he did take the acyclovir through its course. He was subsequently referred by the PCP to the neurologist who changed gears and said, maybe this is migraines. The neurologist prescribed ibuprofen and then referred for dental consultation to rule out temporal mandibular joint disorder and an eye consultation because of the eye symptoms. The dental consultation was done and ruled out temporal mandibular joint disorder. When I saw him, he had intermittent eye pain for the past 2 weeks, which still continue, but he reported that it was worse at night when I probed that question. So I think we all know where we're heading with this. He was 20/20 and 20/40, but that was a consequence of long-standing amblyopia. He had had strabismus surgery at age 6, and he reported that he was anisotrope. He had a narrow angle on von Herrig, low IOPs at this time, 14 and 16. Gonioscopy showed only the trabecular meshwork on the right eye and only trabecular meshwork visible with indentation on the left eye. There was also 5 clock hours of apposition, or what we'll call iridotrabecular contact, and I abbreviate that ITC, in the left eye, and there were no synechia present. Glaucoma evaluation is very clear that this left eye has glaucoma. You see a RNFL defect, even in clinical photography. Here's a relatively normal RNFL. Here is an area of RNFL dropout, and right along the edge of it, we now have a Drans hemorrhage, which suggests progression. Visual field is consistent with that clinical finding. Anterior segment OCT of this patient's anterior chamber angle. You see the apposition here. This is iridotrabecular contact. I'm able to see his trabecular meshwork by doing indentation gonioscopy, pressing down, forcing the angle open, which means it hasn't syneced yet. So there's still, this tissue can be pushed away from it. And here it is up close. You can see how this type of technology is a very useful tool in an eye care setting. So based upon what you know so far, what's your provisional diagnosis for this case? We have primary angle closure glaucoma. This patient meets all of the definition of that particular condition. It's defined by World Glaucoma Congress as ITC, or iridotrabecular contact, in 2 to 3 or more quadrants of the anterior chamber. Increased IOP, which he didn't have in this case. He didn't have synechia, but he did have glaucomatous optic neuropathy and visual field loss consistent with glaucoma. And our treatment is typically an LPI, or laser peripheral iridotomy. Iridoplasty we'll get into in just a bit. I'm going to just pass over this as a general question, but LPI is typically thought of as the treatment of choice. If you're in a setting where you don't have this accessible to you, then pilocarpine would be reasonable to get to at least push the iris away from the anterior chamber until the patient could get an LPI. Patient did get an LPI. This is the OCT, anterior segment OCT prior to LPI, and this is post LPI. When we've done this, we've equalized pressure on both sides of the iris, which then relaxes the iris and opens up the angle. I just want to briefly mention, because narrow angle is actually treated differently in different parts of the world. In the United States, it's really not uncommon for people to get LPIs, even with just narrow angles, even with less apposition in clock hours than the World Glaucoma Congress would suggest. And then there's the issue with plateau iris as well, because clinically, this can be very difficult. And I just wanted to keep this on the list to remind you that when you do gonioscopy, to please include indentation gonioscopy to help you with that differential diagnosis. I know I'm moving all over the place here, sorry. So indentation gonioscopy, because it opens up the angle and gives you a better feel for what type of glaucoma you're contending with, because plateau iris is a different animal. About 30% of patients who have plateau iris and have glaucoma do not respond to the LPI. So I just want to remind you of that, where, doing indentation gonio, or if you have access to this type of technology, it's actually much more easy to see, and actually can be delegated. So in the interest of time, we'll move on. Next case. This is a 56-year-old male. He was operating a mixing board. That's a picture of a mixing board at a concert. There's a very large cable that comes out of it that plugs into an outlet. And he took a shortcut. He was about a meter away from the outlet and just yanked on the cable, and it hit him in the eye. Well, his eyes were closed when it happened, but he noticed decreased acuity, within a matter of minutes. So, I was expecting corneal abrasion, but he was insistent that his eye was shut. And in fact, there was no corneal abrasion, but I did see in his corneal stroma and his corneal endothelium these fine vertical, near his endothelium, the posterior stroma, vertical lines. And these vertical lines don't branch. They're typically straight up and down. And they're a consequence of folds in the collagen lamella and surrounding edema. And the number of these that you see are related to the severity of the trauma. Although I've seen this clinically in what would be seemingly fairly innocuous trauma, but these were pretty profound, and this was his endothelium. So just this clinical picture alone, any thoughts on a provisional diagnosis? That's right, traumatic corneal stria and Breaks and Brooks membrane. And there's a distinction, but and that's where the majority of the answers were those two. Breaks and Brooks membrane, just a different location, but same idea, and a very, very reasonable differential diagnosis. And I'll get to that in just a second. So there are many types of stria, as you know, those associated with keratoconus, congenital glaucoma. Those don't tend to be just vertical, though, because the pressure on the endothelium on the back surface of the eye is in many directions. And when you see vertical ones, as you do in this case, you think about Breaks and Descemet's membrane, to be sure. And one clinical tip, by the way, I'll give you is that when this patient's acuity is reduced and you have the patient shut their eye and press on their globe and then let go and look at these at the slit lamp, you'll see that they resolve a bit, as opposed to Breaks and Descemet's membrane, where that will not occur. And this is the case I'll end on in the interest of time. This cataract surgeon was in our clinic, and he said, "Hey, I got to run this by you guys," because it was fun. The patient's best corrected acuity was 20/60. It had been 20/20 and 20/60. The 20/60 in the left eye was attributed to childhood trauma, but the patient was very sensitive about that because it suggested parental abuse, which he adamantly denied. He never remembers any traumatic events as a child. He did have a history in that eye of anisometropic amblyopia, and it was attributed to very high astigmatism. Externals were unremarkable, pupils were normal, as were IOPs, gonioscopy, and slit lamp was significant only for this clinical appearance. And here's these vertical streaks in here, but these are not in the posterior stroma. These are at the level of Descemet's membrane, and I can show you that. Here they are at Descemet's membrane. The Descemet's membrane has ruptured, and then it's rolled over on itself as it healed. And this is a bona fide traumatic break in Descemet's membrane. These are uncommon, but we can kind of put this all together. It's associated with amblyopia, and it typically occurs early in life, which would be a type of trauma. But why? And here's your answer, is forceps delivery. It is still done around the world, all over the world. In fact, its incidence hasn't really budged a whole lot. And there's two ways typically of when a labor is difficult, either forceps or vacuum. And when forceps are used, given the most common position of a child's head, the forceps are able to get the left side of the face right near the eye on the left side. So most often, this occurs in the left eye. results in amblyopia, but the subsequent healing occurs, but the eye doesn't develop. So it's partially deprivational amblyopia and it's partial refractive amblyopia. I think in the interest of time, this is where I'll leave it. I had a couple more cases, but they're there for you. And you could always, if you don't know my email address, if Andy can get that to you, you're welcome to email me. And this would be a time to take questions on the cases that we've had a chance to discuss. Yes, question about the dislocated lens in the vitreous. Can it cause an inflammatory reaction? It can theoretically. This is proteinaceous material that your immune system has never seen before. But we know from experience with ECCE, for instance, I'm old enough to remember when ECCE was introduced, that was a concern on the part of people as it was evolving, that, look, aren't you now exposing pieces of lens material that, remember, during childbirth, that protein was sequestered. The immune system developed after the lens developed. But as you know, it's very uncommon to have an inflammatory response if you leave a little cortex, for instance, left over in the bag. And so, yes, in theory, it can happen. Very mature cataracts, for instance, hypermature cataracts, where the protein is denatured a bit, sometimes that can cause an inflammatory response. So yes, it can occur. This is an interesting question. It's not really about the cases, but it's worth talking about. Preventative measures with people who had a strong family history of glaucoma but don't have it themselves. What's the risk on the child? As you know, glaucoma, we think of it as the glaucomas, as plural, because there's many forms of glaucoma. And if we stick to the most common chronic open-angle glaucoma, that's typically a disease of older people. And if the parents had it, odds are that's the form of glaucoma they had. Unless, of course, they had congenital glaucoma, that comes out in the history. But even if you knew at birth, if you could do genetic testing to determine who's going to get glaucoma in their lifetime, at what point would you even think of treating them? Because treating them is exposing them to the rest of their lifetime of either meds or surgery that live long enough. Trabs and tubes fail over time. If you did it early in life, you're going to have to likely make an adjustment. So typically, even if with high risk, we don't manage this until we see first evidence of glaucoma. And this is a person that you just make certain that comes to regular eye exams. Is it possible to give topical anesthesia to all? Yeah. If you have a patient who's blepharospastic during an examination, check acuities first. But if it would help, settle the patient down, then yes, you could give topical anesthetic. Just for definition purposes, the question is, glaucoma as an anterior segment condition, is there a treatment? Glaucoma, really, most glaucoma is an anterior segment disease. It just manifests in the back of the eye, and treatment is as there's standard treatment for that, as we know. Yeah, so that's a great question. The forceps don't touch the infant's eye, but how does it cause the cornea to distort? The head, think about this. This head's got to get through a vaginal canal. So it's capable of being compressed. And the forceps are compressing it all the more. So you're getting this kind of force, and that mechanical force is enough to distort the eye. Because the bones of the head are so much more flexible. Even the eye is more flexible, and Decimase is much thinner at that point in development. So enough force in a particular meridian is enough to overcome and enough mechanical stress to overcome the strength of that tissue. That's actually very well documented. Let's see, what is your preferred anterior chamber diagnostic tool? Anterior segment OCT or ultrasound? I've experience with both, and I have no conflict of interest with this. Ultrasound is, you need a good tech. You really do need highly skilled people. It's time consuming. It's messy. It's a little bit messy. I can tell you when our ultrasound goes down, it's hard to get it repaired. And the more I use the anterior segment OCT, the more use I see for it. It's that Z-axis that we often don't see otherwise. or it's just difficult to see. Even documentation, when I send out for LPIs, the surgeons that I work with love it because they see, they don't have to rely on me writing my gonioscopy findings. They can see my gonioscopy findings, and it's not a substitute for gonio. In this setting, it's a good documentation of iridotrabecular contact pre and post. It's also great for educating patients because they can see the difference as well. Educated patient, particularly for involving a procedure and a laser, which is frightening to many people, when you're able to explain to them iridotrabecular contact and show it to them that it's their eye, it's much easier for them to understand. While I'm here, quickly, by the way, patient education, always put my hands together. My fingers here are the cornea. My thumbs are your iris, pupils in the middle, trabecular meshwork, ciliary body, right? And there's your cutaway for teaching patients. You always have these. Yeah, there is a risk of the lens in the vitreous cavity causing an RD. I mentioned that during the lecture because you have healing occur. We have tissue on tissue. That's why we're just watching this patient right now. The risk of going after it is greater than that risk at this point, but it's conceivable that vitrectomy and would need to be done in this ultimately. Oh, so what can be done with patients who have cataracts and are of advanced age, 70 to 80? Do you think eye surgery is still advisable? I'm just going to give a big absolutely positively. And I honestly do not believe that I'm saying this representing where I am in an academic institution. I'm an older adult myself. And honestly, I'm in a glaucoma clinic primarily. And I have patients in their late 90s. I have patients who still do visual fields in their 90s. I have to use a bigger stimulus sometimes, but I still do it. And that lens is just getting bigger and bigger and bigger inside the eye, and the eye is not getting bigger. And it's not just getting bigger, but that nucleus is also denser. And so the surgery itself is more challenging, and it's a quality of life issue. So when the patient drives a train, I don't tell them you need surgery. The patient says, I can't read my recipes. I can't recognize faces, and we need to do something about it. Then absolutely advocate for it. You get the lens out of the equation. You get phacomorphic glaucoma out of the equation, and you just get better vision and quality of life. So if it's accessible where you are, then I would recommend it highly. Oh, transscleral cyclophotocoagulation. Yeah, that's at least in my neck of the woods, that's last gasp. We'll use that for recalcitrant cases of neovascular glaucoma, for instance. When we have a blind and painful eye, it's lower down the list. It's certainly effective, but I think the biggest issue with it in a routine case is that the results are so unpredictable. For the person who asked which is better, a trab or a tube, the TVT study, I would just encourage you to read it, trab versus tube. A lot of controversy there. Either of them are both options in the right hands. I mean, you just have to have a good surgeon. But both, if the patient's young, could fail in their lifetime. So, and I would leave that in the hands of the consultant surgeon. But yeah, read the TVT, trab versus tube study. So what is actually a concretion? A concretion is it's a mixture of debris, dead epithelial cells, sometimes even a little bit local inflammatory response that just brings macrophages to the area as to chew on it, maybe as an antigen presenting cell, but it just doesn't usually incite a very significant inflammatory response, except that chronic irritation, and then the conjunctiva heals over it. So the concretion is just debris. And it's very prevalent in patients with dry eye because you don't have that smooth surface, that phonoceal palpebral tear film. You've got more contact tissue on tissue between the palpebral epithelium and the conjunctival epithelium, bulbar conjunctival epithelium, and that just that those dead cells just get pulled into that and under the epithelium, and you end up with concretions. Also, foreign bodies, chronic foreign bodies. I have many patients who are woodworkers, and the chronic sawdust tends to cause a lot of concretions. They're just entrapped under the conjunctiva. The best routine test for anterior chamber inflammation. Honestly, overall, I still would give the nod to the standard uveitis nomenclature, which is a slit lamp examination using a 1 millimeter beam, high magnification, high illumination. Yeah, older patients in cataract surgery who are in a wheelchair. It's the doctor's call. Sometimes there are really sound reasons. Most of the time it's up to that we let the patient decide when it's time. But when it's not time, I'll give you for instance, I have a patient in their 70s as an example, but based upon what you gave me, a 70-year-old patient who's wheelchair bound, but who has severe diabetes. We need to monitor the retina, and we have to see in, and if we can't do that, then we're putting the patient at risk. So we advocate for that. Another instance would be the lens that's just so large, you now are starting to get peripheral synechia. That's not a healthy scenario. So in that setting, there's clear indication, medical indication, not patient preference, to remove that to prevent this from getting worse. Let me throw this one at you guys too. Alzheimer's dementia. I've had patients from my hospital experience where, I just wish someone had seen them sooner before the dementia had really set in, where they still could give informed consent and it was feasible to take the lenses out. Because on the back end, I've seen angle closure as a consequence, and it's a disaster. So just, tuck that out of the way when you're making these clinical decisions. Laser glaucoma surgery good for Africans. Yeah, 90%. I mean, laser surgery alone is not going to control everybody. I think for early management, I would refer you to the LIGHT study that came out of the UK, 2019, for first line. It's comparable to a prostaglandin, but if you do glaucoma long enough, you know that many patients are going to ultimately need either a repeat SLT or augmentation of management. Okay, so this is a foreign body that's on the cornea, but it's embedded a little bit. So they got the more superficial part that was epithelial, but they have some in the stroma. And I guess the first question I would ask is, make sure if you can get an optical section, go through that and ask yourself, did I breach Bowman's layer? If you breach Bowman's layer, there'll be subsequent scarring. And if it's off the visual axis, you may want to just leave it there. If it's a reactive type of foreign body, such as copper, or copper's a good example, steel, you run the risk of, particularly steel and iron, siderosis. So you would probably then want to remove it. So it really comes down to where is it relative to the visual axis? What's the possibility of the eye reacting in a negative way to it? Or is it inert? If it's glass, it's inert. If it's gold, it's inert. I know gold sounds ridiculous, but back in the day, dentists didn't routinely wear eye protection while they were working the gold on teeth, and I would see my dental colleagues in the hospital would come up with gold foreign body in their eye. Wow. Okay, so couching is still done in some parts of the world. I would just make sure that those retinas are regularly checked, because there's a possible subsequent retinal detachment. How many times can laser surgery be repeated? SLT is, it's relatively safe. I've never done more than 4, not myself personally. I've never seen it done more than 4 times. It's uncommon, and that's over the course of a fair amount of time. And there's no longitudinal study to address that. Not randomized, controlled, prospective, longitudinal. Ooh, so the person wrote back, it's in Bowman's layer, it's central cornea. Where'd it go? Because stuff's moving. And the people, yeah. Yeah, that one center is going to scar. I don't know what environment you're in, but if it's going to scar in the center on the visual axis, the patient will have reduced acuity. You may want that in the hands of someone who has a subspecialty in cornea. Although it's still prognosis for that is of sparing vision is pretty slim. Would glaucoma occur during chemical injury and how? Yeah, the eye can become so inflamed that particularly if this toxic substance is able to get into the anterior chamber, and in some instances it is, and a base is a good example. Acid burns are typically superficial. Alkali burn can penetrate the cornea actually fairly quickly. And any massive trauma like that, you run the risk of a uveitis, and the uveitis inflames the trabecular meshwork, so glaucoma is certainly possible. Yeah. So this is a question about, can you get LASIK if you have a family history of glaucoma? Yes. I think what might underlie that is there's a risk factor for glaucoma, and that's thin corneas. And your corneas are thinner after LASIK, but that's not the thin corneas that we're referring to. That data and that knowledge comes as a consequence of two studies, the ocular hypertensive treatment trial, which show that corneal thinness was an independent risk factor for the development of glaucoma if you were ocular hypertensive, and the EMGT, the early manifest glaucoma treatment trial. But that's not as a consequence of LASIK. That's just the natural biomechanics and structure of these individuals' corneas that may play a role in the development of glaucoma. So an otherwise healthy cornea that gets LASIK is no more at risk of developing glaucoma than if you had not done LASIK. I'm just going to throw this out because you asked, what do I think about corneal inlays to correct presbyopia? I'm a presbyope. I would never do that, but that's just me. I just think you need to, it's patient specific. I would need to be sure that it was in the right hands, but I'm very happy with my glasses. And when it's time for me to have cataract surgery, I'll go with a modified monovision. I'll be a little myopic in one eye and more myopic in the other eye. And that'll give me 90% of what I need to see. At present, I'm a hyperope, which is just terrible. I can't see clearly anywhere without my glasses. So doing LPI, is there a risk of closing the anterior due to residual pigment that might block the trab? There's just not enough. The trab, 360 degrees of trabecular meshwork, you're releasing pigment after an LPI, but not enough to close the angle. So short answer, I think that is a minor concern. In fact, a lot of LPIs end up having a little bit of hyphema, and that doesn't, long term, it resolves itself. Yeah, if you don't know the thickness of the cornea, you can safely do intraocular pressure. You probably know that there's no really good way to account for corneal thickness or biomechanics when doing intraocular pressure. There's a device on the market that measures corneal hysteresis, but if you're measuring IOP, given the precision of these measurements, the best you can do is a very thick cornea is going to give you artificially high readings. A thin cornea is going to give you artificially low readings, but how low or how high is... how does age affect the anterior chamber? The anterior chamber depth shrinks with age because the crystalline lens vault typically increases over time as the lens gets bigger and bigger. Can a vitreous hemorrhage cause microscopic hyphema of the anterior chamber? If you had a breach in the anterior hyaloid face, then yes. Otherwise, the capsule, the bag, and anterior hyaloid face hold everything there. You'd see that if you had the lens removed entirely and you had vitreous prolapse. The non-contact SLT is new to America. That's where I am, and I've only seen it at the World Glaucoma Congress. I know they're using it in the UK, and the UK has a lot of experience with it. So I can't answer if it's effective enough, but I know it's under investigation in the UK and has been cleared here in the United States for use, but I don't have experience with it. So it's a pleasure interacting with you. Thank you very much for your attention, and I hope you have a wonderful rest of the day.